Good afternoon, everyone. Thank you for joining us for our extension of community health outcomes for HIV. I can see we are joined by several people. We have St. Francis Hospital, we have ZAF Clinic in Livingstone, we have Kafue Estates, we have Chipata Central, Mwanangombe, Namuseche. We know we are joined by Lundazi, and Western Mentor, who I know is precious, Mahatma Gandhi, Livingstone General, and Chipata. Sons of Thunder, Maramba, Senanga, and also Kafue Estates. I know I'm very happy I've seen Dr. Humphrey Chanda as well. You are welcome. And Dr. Kenneth Kapembwa, we've been sending him an invite every week, so I'm happy that he's able to join us. Dr. Kapembwa, can you hear us? I don't think he can hear us. Just write him a message, Dr. Kapembwa. But I hope Dr. Humphrey can hear us. I know I saw him here. Dr. Humphrey Chanda, can you hear us?
Yes, please, I can hear you.
Oh, perfect. And you are crystal clear. Thank you so much for joining us. We appreciate. I know he's joining us from the north. We'll soon be rolling out into Wapula and Northern Province. Choma General, you are welcome. Kaoma District, Senanga Urban, Champagne. We hope everyone can hear us. I see Mary Beggars joined us, Lina, James, Helen. And please, if you are using your phone, it means that we cannot address you because we cannot call someone Galaxy Notepad, isn't it? But thank you all for joining us. And here in the hub, we are joined by our colleagues from HW21. We have people from the Adult Center of Excellence, Pediatric Center of Excellence, and of course, our expert today is Dr. Ginwalla, who's a pediatric HIV expert. Before we go into today's didactic, just a really brief recap about the highlights of last week's session, which was given by Dr. Suwilanji Sivile. So he talked about drug-drug interactions, why they are important, because remember, they can lead to failure because once you have an inducer, you may end up with treatment failure because all of that is being lost by metabolism. And one of these examples are things like rifampicin. Rifampicin will lower your levels of dolutegravir, so you have to double it. Rifampicin will lower your levels of atazanavir. We saw that by 95%, so you can't even double atazanavir, so it should never be given with ATT. Lopinivir will go down by 95%, but some studies have shown that once you double it, you may get some effect from your lopinivir. The only problem is that now you get into pill burden. I think one drug to watch out for us is tenofovir alafenamide, TAF, which is being launched next week. We are all very, very excited. But unfortunately, TAF cannot be used with TB drugs. So we cannot combine it with the ATT because rifampicin also lowers the dose of TAF. If you are using an anticonvulsant like carbamazepine, you need to, if you are in the presence of dolutegravir, you have to double your dolutegravir because these drugs interact. I'll let Dr. Rokaya and Joyce actually go into this. I forgot that it's actually for the first time we have two experts in the field of pediatric and adolescent age. Everyone is welcome. I hope Dr. Kapembwa, you can hear us. Dr. Kapembwa, can you hear us? It's very important that Dr. Kapembwa hears us because at least he can give presentation to internal medicine and we can finally get an echo for internal medicine. Chatonda. We are starting with the case presentation. So today we are starting with the case. This is a decision made by our experts today. I'm also just finding out now. We have Sister Mercy to introduce herself and where she's coming from. The echo ID is over there. Please go ahead.
I'm Mercy Mikendo, a nurse counselor from Mount Makuru. I have a case summary here of PD. GP is a male child, 11 years, 9 months, in grade 6 and doing very well. He was diagnosed HIV positive in 2010. He was diagnosed HIV positive in 2010 at age 2 years. at a health center in Makeni. The initial regimen was ABC, 3TC, and loperamide, and nevirapine. In November 2015, at age 8 years, DP was transferred to a facility in Chilanga district. He was kept on the same regimen, ABC 180 milligrams, 3TC 90 milligrams, and nevirapine 200 by 100 milligrams BD till July 2017, when he was switched to a second line. The mother to DP died when he was 5 years old, and DP lives with the elder brother who is married, and the main carer is the wife, is the sister-in-law to DP. In March 2018, at age 10 years, DP was reported to be refusing taking medication, so the adherence was quite poor. Disclosure was not yet done. His VL was still high, at 6,778 copies per mil. With subsequent adherence counseling, adherence for DP improved. DP is now about 11 years. Main caregiver is the sister-in-law, who is reluctant to disclose on account that DP is not a blood relative. The brother to DP has a mobile job. He's always away from home. The last visit, the physical examination for vital signs for DP, the height was 137 centimeters, weight 29.2 kgs. The BMI was 15.5, blood pressure 125/60. The pulse rate 82 beats per minute, and temperature was 35.7. The Turner staging was stage 2, and DP had no cognitive impairment. On the clinical timeline and lab results, when BP was transferred to Chilanga, was on ABC 3TC and nevirapine, that was on 2010. And then on arrival in May, we did some tests, which was HB, white blood count, creatinine, CD4. And the CD4 in May 2016 was 716. That was the baseline at Chilanga. In July, the viral load was repeated because the GP was not taking his medications properly. And the viral load went up to 4,417. Adherence counseling was done, and DP was switched to the second line. Though there were still reports that there was poor adherence. We repeated again the viral load in May 2019. After extensive adherence, the viral load came down to less than 20 copies. But the problem is the disclosure. GP hasn't yet been disclosed to, because the sister-in-law, who is the main carer here, is not ready to disclose. Now the questions that we have are, who should disclose to this child? and what information should be given to the child at this age of about 12 years?
Thank you very much, Sister Macy. I'll allow Dr. Rokaya and really to give us the salient feature. It's a very long case. What is this story? Can we summarize it?
Okay, so this is a case of a child who has been referred to us and he's had treatment failure, so he was switched to second line. And along the way, we find that he's had poor adherence and that the caregiver he has is a sister-in-law who feels that it's not her blood relative, so she's not in a position to make a decision to disclose to the child. And when we talk to the child, he had no idea what he's taking. So the issue is adherence and the issue of non-disclosure. So we wanted to discuss disclosure, the topic of disclosure. After our presentation, we can come back to these questions and see what you think about who should disclose and what information should be given.
Okay, I see that he's in grade 6 and doing well.
Yes.
From what I can see. And it looks like biologically he's now suppressed.
He's now suppressed, yes.
Okay, so we'll take some questions from the network as we discuss this case. At this point, we'll stop sharing the screen, Chatonda, and allow the network to ask Mercy and Dr. Rokaya any questions that may help them answer these questions on who should disclose and what information should be given to this child. I don't know if there are any hands. Okay, so your phone, if your phone is named Galaxy J4, please rename it. I don't know if Victor's hand is up. Can you see any hands? Okay. So we have a case of somebody who's almost 12 years, but they're having disclosure issues. Unfortunately, mom died when he was only 5 years, and now his caregiver is actually his brother, who's never home. So he's got a wife who seems to be doing most of the job. This child has been on ARVs for quite some time, actually, since he was 2 years old. He hasn't been told why he's taking the meds. So along the way, we've had some stumbling blocks. He's had some viremic periods of 6,778 copies of Virion at some point. But the good news is that he's on second line and seems to have suppressed. But the team is asking, this child is 12 years. Who should tell this child that you have HIV? That's why you have to take this medication. At this point, we'll get some questions from our network. Patrick, Doctor, I will ask Patrick Kabula from Matero. Do you have any questions for Mercy?
Yes.
Yes, Patrick. You have another. Is it him or us?
Yeah.
It's him?
Hello.
Patrick, I'm going to mute you and say, please switch off one of your devices and focus on one. We are getting a lot of feedback. Then go ahead with your contribution and question before I go and maybe check on ZAF Clinic for their comments and contribution. So ZAF Clinic, you can prepare yourself.
Hello.
Patrick, you have 2 devices playing, so we are getting a lot of feedback. While we wait for Patrick, ask him to make Zaf, please go ahead with your question or contribution. Dr. Cheche. Are we having feedback from here or what? Okay, Patrick, I see you with Rodrigue. I'm unmuting you to allow you to go ahead. I'm sorry about that. Let's unmute Rodrigue to allow Patrick to ask. I'm trying to unmute him. So Patrick is our mentor for Matero. Please unmute him. He has something to say.
I think, why don't we do that?
Are you able to unmute yourself? We can't go back.
Yes, Doc. Are you able to get me?
Yes, Patrick, please go ahead.
Yeah, so like following the case, I have observed that looking at the viral load this child has, she's having the rebound, like the initial viral load, and again the viral load has gone high. So we are having a challenge here of adherence. So I'm most wondering if the child is taking treatment effectively. So I would like to find out from the nurse at Mount Makuru, like looking at the caregiver of this child, are they able to, first of all, counsel the caregiver of the child on what HIV is all about and the issue of treatment? Because if this caregiver is not properly counseled, this child won't be able to get treatment effectively, and they will still continue becoming suppressed, and they might even fail the second line that have been placed on. So what have they tried, like, to educate this caregiver? Because if the caregiver doesn't have the knowledge, there's always that fear of saying, how do I disclose the child? I mean, or maybe to the adolescent. So have they been educated adequately enough so that they can be able to help out this child? Because adolescents, sometimes as they are growing up, it's very difficult for you to, for them to adhere to treatment. So they need proper information, full information on the HIV, and then we can pick it, we can now continue from there.
Thank you so much, Patrick. That's both a contribution and a question. He says, how much information have you given the caregiver even before you start talking about the child? His concern is that you may start seeing this swing in the viral load. I think that's a very brilliant observation, because from my end, I was thinking, well, he's at less than 20, it's fine. But Patrick is concerned. You are moving from 716, which is, for intents and purposes, suppressed. The next time, this child is in 6,700. So he's concerned you have the swinging up and down. What's going on? What have you told the caregiver, even before you ask us about the child?
Okay. Thanks very much for the comment and question. We have had sessions with the sister-in-law, the caregiver, especially when the viral load went up. And when we discovered that the child was not taking the drugs accordingly, so we had sessions with the sister-in-law just to educate her or counsel her on how to handle this child who is HIV positive and how important it is for this child to be taking his medication. So we are still counseling the caregiver. It's only that we are having difficulties on disclosure, because she says, since I'm not the blood relative, I cannot disclose. So we have gone ahead to talk to the brother-in-law on phone, because it's like his work is mobile. So we are still trying to counsel the caregiver on the same DP so that this child can continue taking the medication accordingly.
So that's interesting, Mercy. So the giver is she's the sister-in-law.
Yes.
We all are aware of the cultural barriers, isn't it?
Yes.
Is she even the right person to do this? She'll end up with no marriage, eh? And for us, I know for everyone, marriage is important. You don't want to end your marriage over wrong disclosure. So anyway, we'll ask Precious, one of our mentors from Western Province, what has been your experience with adolescents? Is this common? What's your experience on the ground in Western Province?
Okay, I've had a few encounters of some parents not being able to disclose, especially in the rural areas. But in town, because of the adolescent support groups that are now coming up, it has eased the work of the healthcare workers together with the guardians and parents to actually disclose to these adolescents that are on treatment. So I had an earlier comment to the same facility to ask them how the relationship is between the aunt, I'm not sure if the aunt and the same child, because the relationship also can affect how the disclosure can be. and also to determine actually who actually do the disclosure to this child. So if their relationship is not okay, it can also affect how the information will be disseminated, or maybe that is why she's afraid, because back home maybe she's being mistreated, or he's being mistreated at home, and he can't accept any information. Everything the woman will say will be all lies and just something to the adolescent. So it's very important.
Thank you so much, Precious. Chilenge, please go ahead with your question. We are muting you now. Only one device per room. Thank you. Dr. Onoya, I can see you. Go ahead with your contribution.
Yes, good afternoon, Dr. Sombo, everyone.
Hi, Naya.
Yeah, thank you for this presentation. The case seems easy, but it's very complex. Just taking into account what Precious is from saying, I think there is need to conduct a deep assessment of the environment. And it's not just the issue of disclosure, but there is also the issue of psychological support. So I think it will be very important to bring in the brother, though he's very mobile, but it's important to involve the brother and to link the child to the adolescent, to an adolescent friendly corner. On top of that, I've noticed that the BMI is, I've said 15. So I think this child also needs a nutritional support. Thank you.
Thank you so much, Dr. Onoya. Chilenge, looking good. We put you on speaker view and we're able to appreciate that. I don't know if we should take any more contributions, Dr. Okaya, or go into the didactic.
I think we can proceed to the didactic.
Okay, so Jatonda, allow me to share my screen. Okay, thank you so much. I just want to check, Dr. Kapembwa, can you hear us now?
Yes, I can.
Perfect. Okay, I'm so excited to have you. You're very welcome.
Thank you.
I look forward to us doing this for internal medicine.
We'll definitely do it. We are actually we're exploring this avenue. So this is a welcome way of communicating.
Thank you so much. So Dr. Kapembwa is my boss, and he's a nephrologist, he's a physician, he's a great teacher. So I'm excited to have him here. It's a privilege for us. And would like to see this for other diseases in Zambia, where we know HIV is a great public health issue for us, but we know hypertension, diabetes, renal disease, a lot of other things, malignancies are on the rise. So we all need to be aware of that. So we'll go into the PowerPoint. I want to acknowledge the presence of Tanzania. You are very welcome to our echo session. You can unmute Tanzania if they want to say something. Tanzania, you're welcome. Would you like to greet us? Can you see Tanzania? Yeah, online.
So, hey, Sambo, it's Bruce Reminger here. We've got a whole room of HIV facilitators, infectious disease clinicians, nurses, people, laboratorians, and they're all super excited to be part of your ECHO. Thank you.
Thank you so much, Bruce. I'm sure you do as good a job as you did here. Thank you for joining, Bruce. We'll now go into the presentation. Dr. Okai.
Thank you all for joining us today on the ECHO program, discussing the disclosure process. And I have with me Joyce Mwanangombe. She's also with us working at the Pediatric Center of Excellence as one of our nurse counselors. Next slide. So the objectives for today, first of all, to explain epidemiology and talk a little bit about the adolescent epidemiology in general. Then we'll define some terms regarding adolescence and disclosure. We'll also talk about the developmental approach as a process. As we talk about disclosure, we need to take into account developmental milestones of a child and how much they can absorb at what age. We'll discuss the healthcare workers' role in supporting caregivers through the disclosure process, as well as supporting the adolescents. And we'll end up with some studies that were done in sub-Saharan Africa on disclosure. And finally, I'm happy that we'll be able to share with you the latest resource that has just been released last week, which is a New Horizons disclosure toolkit. So we'll be able to share with you on the website. And you can download the toolkit. It's a very comprehensive toolkit that was tested and validated in this part of the world. So it's useful for us. Next slide, please. Okay. So regarding adolescents in general, globally we have about 2.1 million adolescents living with HIV, aged between the age of 10 and 19. And it's estimated that by 2030, this number there'll be an additional 3.5 million adolescents living with HIV if we carry on at the rate that we are going. 85% of the adolescents infected with HIV live in sub-Saharan Africa. In fact, 50% are living in just 6 countries that are within this region. So they account for half of all the adolescents we have. 260,000 new infections among adolescents annually. And 3/4 of the new infections in this part of the world are in girls aged between the 15 to 19. In terms of mortality, in adolescents, the HIV is the 4th leading cause of deaths in sub-Saharan Africa. So you can see why we are so worried about adolescents. So it's where the epidemic is sitting, and if we do nothing about this age group, we'll have a bigger problem as we go ahead. All the gains we have achieved so far will move backward. So I'll define some terms. Adolescence is a period of physical, psychological development, and it starts from the onset of puberty right to full maturity. WHO defines adolescence as the age between an individual age between 10 to 19 years. And in terms of disclosure, the definition of disclosure is that it's a process which is ongoing, where you provide information to a child as they mature. And that maturity takes into account their cognitive maturity, emotional, social, and sexual maturity. And in this process, you have to help them understand what it means to have HIV. And it's also a process in which you help the child to disclose this status to others. Disclosure also involves speaking very truthfully to the adolescents over time and not telling lies or giving deceptive or deceiving the child. Disclosing or helping the caregiver to disclose the status at the appropriate time according to the child's need is very important. So we'll go into the polling questions now.
So we're going to launch our first poll. I hope everyone can see. I will read it. When is the most appropriate age to disclose HIV status to a perinatally infected child? Oh, wow. Boom. Okay. So we have one person voting. We expect more than 20 votes. When is the most appropriate age to disclose the HIV status to a perinatally infected child? Why should you tell a child that they have HIV? So you have the option of 6 years, 10 years, 15 years, or the above. So we can see we have 9 people voting. So we need more votes. We need more votes. We need more votes. I like this because we can see that really it's almost, quarter across, there are different opinions. Okay, and I'm sure there's cultural intonation as well, which may be very subtle and difficult to explore, isn't it, in our culture? I know for us, even a lumbar puncture, they'll tell you they want to ask a grandfather in the village who's not a doctor if they should have a lumbar puncture. So here you go, Dr. Okaya. Most people actually, almost 50% feel that someone who's 10 years old should be disclosed to. But of course, there's some people who feel that it's 17 years old. And 9% which is 4 out of the 44 people voting feel that it should be at 15 years. Some people feel that all the above, do it at 6, do it at 10, do it at 15. It will be interesting to see. I'm going to end the polling and just show you what it looks like so that as Dr. Rokaya goes into her teaching, we are able to think about it. So you can see almost 50% think that 10 years is the right age. It will be interesting to know which one is right. Thank you all for voting. I'm going to end that just now. So our next poll question: who is responsible for the disclosure? Who is responsible for telling the child? Is it a parental caregiver, that is mother or father? B is the healthcare worker, which is you and me. Are we responsible for telling a child that you have HIV? There is a non-parental caregiver, which is aunties, uncles, cousins, grandparents, okay? So then all the above. Okay, we need more votes. I know we have a lot of people joining us. Okay, so a number of people feel that it's a parent. It's a parent's responsibility to tell this child that you have HIV and that's why you're taking this medication. Then you have healthcare worker, you have the non-parental caregiver, and you have the above. I know I once had an adolescent who was failing treatment, and it was very unfortunate. We were trying to figure out why, and he says that, no, actually, where I'm living, my cousins, once we fight, they will tell me that we don't like you because that's why you have HIV, and that led to a lot of non-adherence. It's just something that we didn't even think about, that the younger children were teasing that child because they have HIV. So anyway, almost 50% feel that it should be the parental caregiver. Actually, B and C, no one thinks it's a healthcare worker for now. No one thinks it's a non-parental caregiver. That's the grandmothers, the aunties. People feel it's either the parental caregiver or all the above. So these are the responses you have, Dr. Okaya. Thank you, Dr. Thomas. So I'm going to share the results so that everyone has a look and we all think about it as we discuss this very important topic personally, because I'm seeing us eliminating pediatric HIV. So these pediatric patients, they'll become adolescents. And, we saw that very high rate of transmission, especially among our young women, especially among that age group. So this is how we are looking. Thank you so much. We shall report at the end of the session.
Okay, I'll hand over to Joyce now to talk about more into the actual approach of how to disclose.
Good afternoon, and thank you very much. We are now looking at the developmental approach to disclosure. So decision about when to start the disclosure process with children or adolescents are determined by the readiness of the caregiver and the developmental stage of the child. So if a child is about 6 years or 7 years and is asking about why he's taking medicine, this is the right entry point. It means the child is ready to know why they are taking medicine or ARVs. And each phase of development has characteristic features. Understanding developmental stage and needs is vital to disclosure and will help ensure that information is presented when the child or adolescent is able to cope with it. Because if we tell a child who is 6 years old they have HIV, imagine what would happen at home. It would be chaotic. But when we find that this child can comprehend and we discuss about HIV to them, they'll really understand and appreciate. Developmental stages are related with approximate ages, essential to ask questions to assess each adolescent's understanding. So when they start asking questions, they want answers, not lies, but the truth. Start talking about disclosure with caregivers well before the child is an adolescent. The perinatal children have been taking medicine, ARVs, and they want to know why they are taking medicine when they are not sick. So they should be able to be told at that particular time. Ideally, the child will already know their HIV status by the time he or she is an adolescent, because they can read, they have clues in the clinics, in the adherence room, we are talking about HIV, and they are listening, but they are waiting for the ideal time when they should be told officially by whoever is taking care of them. Reasons to disclose to a child their HIV status. Why should we tell them? According to the children's rights, children have a right to know what is wrong with them and where they are taking ARVs. They are asking to know what is wrong with them because now their cognition is improving and they can see that other children maybe in the homes are not taking medicine. Why them? Non-disclosure may lead to incorrect ideas about HIV. Adolescents may feel alone, learn status by mistake, or have poor adherence. When adolescents learn their HIV status by mistake, then a problem arises because they may completely refuse to take the medicine, or they'll hate the parents or whoever is taking care of them. We have had issues in the clinic where a child comes and just opens the file and finds it's written HIV, and they haven't taken that very well. Disclosure may reduce stress levels, and help them to seek service and to understand why they may have lost a parent, because they'll be able to know that, well, my parents could have died of HIV. Adolescents may already be receiving intended clues, as I've said, of their diagnosis at the clinic, and they can take an active role in care and treatment. When they know what's wrong with them, you find that they may be in denial at the beginning, but later on they will appreciate and learn to be more responsible about the need to take medicine every day. Levels of anxiety, depression, and low self-esteem are higher in adolescents who have not been disclosed to. They may have clues, of course, they can even see the ARVs on television. So they have stress because they are seeing those bottles and referring to what they have in their bags. Then they'll be saying, oh, it means I'm now taking ARVs, but why are my parents or grandparents not telling me? So they need to be told to allay anxiety. Now we're looking at types of disclosure, and we have to move systematically, because if we do it haphazardly, we are really going to stress the adolescents and the children. So partial disclosure, we should consider partial disclosure around the age of 6, when the child begins to understand the concept of illness and its causes. So they'll know that illness means this, and they'll know that illness is caused by germs or viruses. They'll ask because they learn at school. It refers to give information about the illness without using words HIV or AIDS, but avoid lies and deception. When these children are told that they have got sickle cell, they've got TB, in the future when you want to disclose to them fully, they may not trust the caregiver or the parent. So the children or the adolescents at that time, they should be told, when doing partial disclosure, they should be told they've got a germ or a virus, so that when it comes to full disclosure, we just add on. It's advisable to encourage discussions in the home about health and well-being, diseases, hygiene, and self-care, just to sit at home so that they can discuss and understand what it means to be sick and what diseases are. And when you ask them about why children come to the hospital or why people are coming to the hospitals, you'll be amazed that children are able to mention even HIV. Partial disclosure helps move disclosure process forward and prepares for the full disclosure later on. And it is an effective strategy to help caregivers who do not yet feel ready for full disclosure. So they may disclosure partially, tell the child you have a germ or HIV. While they are getting ready, they are being educated on how to disclose fully. And full disclosure refers to when a child or adolescent is specifically told about HIV status and given HIV-related details, such as how HIV is transmitted, how it is likely contracted, and you talk to them about, they understand the basic facts of HIV. So full disclosure is recommended when child is developmentally ready to receive the information, usually around the ages of 10 to 14 years. Important indication for full disclosure is when a child asks specific questions about his or her illness, and we are saying that is the entry point. Other types of disclosure. Complete non-disclosure refers to complete secrecy around the diagnosis, not providing any information or telling the truth at all. Then you have accidental disclosure, which I just mentioned, where a child just hears about it suddenly, disclosing about the HIV status with no preparation at all. And this is often unintentional. And of course, deception, where ascribing condition to a different illness or linking it to behavior and appearance, or say not eating enough. Children are not being told, or adolescents are not being told the truth. Healthcare roles in disclosure. And these are our roles. You there and me here talking. Usually, primary caregivers should disclose to the child, but may ask for help with the process because some of them are not sure how to begin. Healthcare workers can prepare the caregiver and help decide what information to give to the child and when, given the child's age and maturity. When we are asked, as caregivers can be in attendance when, as healthcare workers can be in attendance when caregivers talk to the child, to give moral support and to encourage and to ensure that the child is being given the correct information. Caregivers may ask healthcare workers to take an active role. We should be prepared to do that. Even if we say healthcare givers should disclose to the child, where they have challenges, we should come in. And healthcare workers may be involved in disclosure conversation to assist the caregivers. So healthcare workers should encourage open discussion about disclosure and offer practical strategies tailored to family situation, because each family is an individual, each child is an individual, so we look at their family situation, and that's also an entry point on the healthcare workers. Healthcare worker barriers to disclosure. Healthcare workers may find it difficult to discuss disclosure with caregivers themselves, ourselves as healthcare workers, we may find it difficult. When the healthcare workers may not know where to start or may be concerned about harming the adolescent. Others will say the child is writing exams, the child will kill himself, all sorts of experiences. Healthcare worker may be unsure of their role or think that disclosure is not their responsibility. Healthcare workers may experience differences of opinion with caregivers or among other workers. Before that, before literature review. Okay. So, healthcare workers may experience differences of opinions with caregivers or among other healthcare workers within ourselves. Some will say the child is ready, others will say no, don't disclose. So within ourselves, we have got barriers and challenges. So we should be discussing and defining our roles in disclosure process with the members of the multidisciplinary team so that we all do the same thing. And like when in the adherence room, adolescents are being told they can be disclosed to, they go somewhere to the clinician will say, wait, and here and there. So we should all discuss together as a team, and then we say, when should we tell this adolescent, or are we able to tell the adolescent now, or is the adolescent ready today? So it should be a multidisciplinary team, and it works better. So we have the literature review there.
Okay, thank you. Thank you very much. I'll come back to the presentation. I thought we should go through some literature around disclosure, especially in our region. It's a big issue. One of the greatest challenges for parents at this point of those who are infected with HIV is how do you disclose to your child about the HIV seropositive status? Unfortunately, the literature shows there's very little information. I think all in all, there were less than 20 studies done around disclosure, which were from sub-Saharan Africa. And we cannot translate the studies that were done in the West because the situations are quite different for us compared to them. So I decided that we should stick to studies that were done within our region. So in a review that was done in 2016, this was a systematic review of literature looking at all the studies. The reported disclosure rates varied quite a lot. It's from 11% to 38%. I'll go through country by country some of the studies that we've had a chance to review. This one from Malawi was looking at healthcare workers in ART clinic, and this was nurses, clinical officers, and counselors. Sometimes they had a doctor, but mostly it was nurses, CEOs, and counselors. So 98% of all the healthcare workers said it was important to disclose HIV status to the children. However, only 37%, up to 37% reported that they had never disclosed HIV to the status of HIV to a child. And these are people working in ARC. Half of them also estimated that the rates of disclosure at their facility was less than 25%. And they cited the barriers to disclosure as lack of training was one of the biggest ones, lack of standardized tools, and also the unwillingness of caregivers to disclose, that they always came up with a lot of excuses to try and postpone it. So we'll go to the study that was done in Uganda. This was a study that looked at the caregivers' attitude to testing and disclosure. And in this study, all the caregivers that were approached or that they had focus group discussions with had disclosed to their child that they had HIV. So 64% of the caregivers said they sought advice from the counselor prior to disclosure. Unfortunately, the information they got was not very key in helping them to do the disclosure. So there was no clear guidance, and the key areas that needed to be addressed around maturity and understanding were not addressed by the healthcare worker. The mean age of disclosure for this study was around 7 years, and the caregivers expressed doubt that the child understood what they were being told, because I think 7 years was quite low for them. They were quite young to not comprehend what it means to be HIV positive. And caregivers also had the view that the disclosure was a one step, that once you told your child you were HIV positive, then that was it. They didn't really have an ongoing discussion around it. It was just a one-off information and it ended there. So in the same study, the caregivers admitted, 42% of the caregivers admitted that initially they just told their child they were sick because they had some other disease like TB or malaria. The study concluded by saying that pre-disclosure counseling and HIV education and how the healthcare professionals are trained to facilitate the disclosure are important avenues to explore. We move on to a study that was done in Kenya in 2015. In this one, both caregivers and adolescents were interviewed. The majority of caregivers had not disclosed their HIV status to their child. That's about 62%. And commonly, the caregiver was the biological mother. On average, full disclosure happened at the age of 11 for this study. So caregivers express reluctance to disclose the HIV status to their children because they perceived psychological and emotional trauma, and especially thought the child would become suicidal if they were told that they were HIV positive. Another big fear they had that if you told your child about the HIV status and other people outside the family heard about it, it would be a big, they'll have a lot of stigma and discrimination. And also they blamed that the child, they also felt the child would blame the caregiver for the infection. And they they felt that the child would equate them to being immoral or being promiscuous because they themselves would be infected. So we'll continue with the caregiver's perspective. They also said that the children often started putting pieces together. They kept coming to the clinic, they read the billboards, they looked at the medicines, they could put 2 and 2 together and know that there's something going on and they might be HIV infected. And this, they felt, made it very difficult for them to disclose because they didn't know exactly how much and what the child knew, and then they found it very hard to disclose. And the common reasons that they gave the children for taking medication were that they had rashes or TB, malaria, etc. So in the same study, when they talked to the children's perspectives were quite different. None of the children mentioned suicide at all. They didn't have any feelings like they wanted to kill themselves. But they said they had initial shock when they got their diagnosis. And also some days of being very sad or feeling shameful or having some kind of guilt. But most often these feelings were short-lived. They blamed the caregivers for lying to them about their status and not disclosing sooner. So they felt that there was a lot of deception going on. And they did understand the caregivers' concern about them keeping this HIV a secret. In fact, they felt also that they themselves had a concern about their ability to keep a secret. So that was something that came out in this study. Again, the children preferred a lot of secrecy, and all of them said they felt very uncomfortable or ashamed if they had to take the medicines in front of others. So most of the time they took the medicines privately. They largely denied knowing their HIV status before they were directly told by the caregivers. You saw earlier that the caregivers had this suspicion that the child had some idea, whereas the children were saying, we didn't know anything until we were actually told. We came across only one study that was done in Zambia, and this one was focused on barriers and facilitators of disclosure. And it has perceptions from both the caregivers, the healthcare workers, and adolescents. So in terms of barriers from the caregivers and healthcare workers' point of view, the issues that came out was that the local norms about talking to your child on sexual and reproductive health, it was felt like parents failed to communicate around this issue. And this was a big deterrent to disclosure. In fact, they preferred that it was the grandmother or the aunt who did the disclosure rather than themselves, because when it broached on sexual issues, they didn't know how to talk about it. Again, fear of HIV stigma and discrimination, if it was the status was known by others, was a big concern. There was also an underlying presumption that the adolescents really don't understand very much about what it means to be HIV and what impact it has on their lives and their relationships. And both healthcare workers and caregivers didn't know when was a good time to disclose. So in the same study, looking at the adolescents' perspective, they all said most of them had their diagnosis disclosed to them because they were very inquisitive and kept asking, what's wrong with me? Why am I taking medicines? Why should I have to keep going to the hospital? So those kinds of questions prompted the disclosure process. Then they also reported they spend a lot of time in school and they have a lot of close friendships in school. But when it came to disclosure at school, that was very rare. They were comfortable only to disclose to their peers and those they know in the clinic who shared the same burden that they had. An additional barrier to relating to the adolescents was disclosure to the sexual or romantic partner. Some of them had boyfriends and girlfriends, and some of them also had children or in a sexual relationship. And most of them found it very hard to disclose to these partners. And this is of concern, especially if we talk about prevention efforts. In terms of facilitators to disclosure, open communication with caregivers was one of them, as well as with healthcare workers. Family-centered approaches, using the other members of the family, like I said, the grandparents or the aunts and uncles played a key role. And positive messaging around HIV diagnosis, like giving a positive message that treatment is there, that treatment is easy to take, things like that were appreciated. So I'll end by giving you some key points on this topic, that disclosure is not a one-time event. It takes a long time and there's no right age for disclosure. Even though WHO recommends that full disclosure should take place by it's an ongoing process and can start from an early age just by discussing health issues. Disclosure has many advantages and will benefit both caregiver and children. It is best done by the caregiver or trusted family member and should be facilitated by the healthcare worker as much as possible. Healthcare worker can work with the caregivers and adolescents to help them to prepare and understand why disclosure is important and to support them through the process as time evolves. I'm very happy today to share with you a disclosure toolkit, which has just been released last week, Thursday. There was a live webinar where it was presented. This is the website where you can download it from. And I went through it. It's really, really very useful because it talks about the readiness assessment. And in this, it talks about you have to assess the parents, how ready are they? You assess the child, how ready is the child? And it gives you practical tips on what to look for in these assessments. There are also a lot of role plays and examples of how to do this. So I think all of you who are listening in today, please take down the details of this website and if you can share it with everybody else in the clinic because it's a good starting point and very useful for all of us. As I said, this tool was what do you call it? Used in Malawi, Tanzania, in some of the neighboring countries. So the practical experience from these countries, which have the same social and cultural environment as ours, were taken into consideration. Okay, those are my references. And we'll go back to the polling questions. So I'm sure by now you know the answers after this lengthy discussion.
Thank you so much, Dr. Roka. Thank you so much, Joyce. We'll do your polling questions again after what has been discussed about disclosure. It's a process. It starts somewhere around 6 years. By 12 years, you should have had full disclosure. But I would like to imagine, we know that several studies have shown that HIV, the first place it goes to is the brain. So they may have neurocognitive deficits. They may not achieve the milestones at the same time as somebody without HIV. How do you account for that in terms of disclosure? This
is why we need to do the readiness assessment. It goes into full details about how you want to know about the child, how do they relate to their peers, how do they behave in the family, how is their progress in school, what kind of activities do they engage in. So if you look at the toolkit, it gives you the clues on exactly what to look for, and then you know that this child is ready and this child is not ready. And definitely malnutrition also plays a role. We have high rates of malnutrition apart from HIV itself affecting the brain. Even the malnourished children tend to be, their mentation tends to be slower.
Slow. So I'm getting the sense it's not just about saying
it's not about
you are
the
12
age.
years you should have fully disclosed to, isn't it?
Yes.
Because I mean, if I have a certain element of mental retardation, 12 maybe. I may be functioning at the level of a 4-year-old. So it's a very, I get the sense, it's very comprehensive. You assess the family, you assess the child, what the home situation is. Okay, I guess we can go back into our to our polls after that talk and hear what people think. I'm trying to relaunch it. So there we are. When is the most appropriate age for us to oh wow, for us to tell somebody who's perinatally infected? I'm wondering, why did you say perinatally? I know 95% of childhood HIV will be perinatally, then 5% maybe through sexual abuse, and sometimes at 11 they are having sex. So that's, I guess, a different process, isn't it? Because they are affected by a whole different spectrum of disorders. So here you go, Dr. Rokaya, after your teaching, at what age, what is the most appropriate age to disclose HIV status to a perinatally infected child?
I'm looking at the numbers now.
Yeah, so only 29 people have voted. So we have about 10 more people. We are waiting for votes. We see you not voting. Yeah. When is the most appropriate age to disclose HIV status to a perinatally infected child? Remember, adolescence is from 10 to 19 years old. Remember, by 6 you should have started. We hope by 12 you would have done it. But remember, there are a lot of factors that go into a disclosure other than just age, I would imagine. So here are your responses.
Okay, yeah, we were hoping we'd get a better response. The answer for me is D. It should be at all of the above. There's no age that you can say is the right age. And I think I concluded my slide that there's no right age. So it should be at any age. And you start talking about disclosure from an early age. From 5 years, you talk about germs, you talk about diseases. People know about cholera, people learn about malaria in school. So really, there's no age. Age is not the issue. The issue is how ready is the child and how ready are the.
Would you like to comment, babe? Maybe we were too hard lines here. 6 years, when you told us you should start at 6, 10 years, you said, oh, it's okay. 15, I'm thinking, oh, they're a bit grown up. But I mean, if I'm functioning at the level of a 4-year-old and I'm 15, maybe 15. So would you like to just touch a bit on those ages and how you came to say all the above?
I think from what we've just said, that you start from an early age. So by the time someone is 5, 6, you're already discussing illness, health, disease, self-care, issues around. So that already is a step towards disclosure. Just talking about health and well-being is a disclosure process. It makes it easy. That's like doing partial disclosure. So even if you are so young, you're not going to mention HIV per se, but that's beginning to do some kind of disclosure.
So what I'm hearing,
as a child, So
what I'm hearing you say is that by the age of 6, you should start thinking about it, to be honest. But we should be cognizant of the fact that because there are so many factors, as you are saying, if they are malnourished, they may be 6. You probably will fail to start. If you are getting a 15-year-old who's not disclosed to, I think you should be aware that, okay, it's delayed. What are the issues? And, so unfortunately, if you're meeting someone at 15, it could be at 15. Okay, so we should start early, right? Okay, no, so we are going to go to our second poll. I hope you do better, Dr. Rokaya, the second one. Okay. So here's the second question. Who is responsible for the disclosure to a child? Is it the parent or caregiver? Is it the healthcare worker? Is it the non-parental caregiver? Is it all the above? So I have a couple of votes. I wish to say, I think I saw Stephen Zulu. I may have hidden you with that. I believe this is ICAP. I went to school with him, and I'm seeing Dr. Chimuka, a pediatrician. You are welcome. We see you, Chimika, actually. You need to rename your device from M5 Chimika. You need to put your name. You go to participants and change that. So who is responsible for the disclosure of for disclosure to a child? Is it the parental caregiver? Is it the healthcare worker? Is it the non-parental caregiver? Is it all the above? I don't know if Joyce or you, and I will give it a chance. Okay, I kind of like what I'm seeing. I don't know if are the folks able to see this, what I'm seeing now? Oh, okay. Okay, we'll share the results soon, but they look better. They look better. I would have liked it to be 100% of the correct one, because this one is definitely, but also maybe you guys don't know how to set the pose. Who is responsible for disclosure to a child? Whose responsibility? Is it the parent? Is it the healthcare worker? Is it the non-parental caregiver? Is it all the above? So I'm going to just share the result. It's time up. And I know Dr. Oka and Joyce want to discuss the case a bit, because we didn't zero in. So here is what we are looking like. Do you want to talk about this, Dr. Oka?
Joyce, say something.
Thank you very much. So when we're looking at who is responsible for the child to disclose the HIV status, we are giving the answer, we agreed on D. Because when you look at our setup, especially in our country, the children and adolescents are kept by so many people. When they don't have, when their parents have died, the grandmother will keep the child, the uncle, and in our case, it was the brother. So you find the aunt. Most of the time, it's the aunt and the grandmother. So whoever is closest to the child is the best person to disclose the status to the child, and most especially those who live with them at home. Because if they are disclosing at home, it should be in a nice setup where there's no noise. The child should be prepared, psychologically prepared, so that when this caregiver or the parent is disclosing, he or she should be ready for the outcomes of disclosure. How will this adolescent react? And they can best react well at home. Can you imagine in our health institutions, and we are disclosing? We have come across children who are in a crisis. They'll keep on crying, and you can see the time it will take for the health caregiver to bring this child to cool down. So it's better it is done at home, in their own environment where they are used. And like in the clinic, we can facilitate in the clinic, but ideally it should be at home by the people that are closest to these adolescents and children.
Okay. So all the above.
All the above.
Yeah, all the above, because I think we shouldn't leave it just to the parent or caregiver. I think we have a role to play, and that's the reason why we thought the right answer should be all of the above, because the healthcare worker has a role to prepare the caregiver on how to disclose and what to say and what to look out for, and just to do an assessment to say when is the right time, or is the child ready.
So I would like to give this question some context. We know that most perinatally children, or at least here in Zambia, they are OVCs, orphans and vulnerable. So they won't have a parent. So if I say, I'm your auntie, your parent should have done it, but your parent is dead. But in a situation where somebody has a parent, there's an uncle, really it should be the parent to do it. But remember, from the studies that have been done, the parents usually, they're scared of traumatizing this child. This is a heavy thing to say. So they may co-opt somebody that may be really more comfortable with telling the child that actually you have HIV. And sometimes between the parent, the aunt, and the healthcare worker, they may come up with something. Because we need to remember that, these children, sometimes they're kept by grandparents who really don't know what HIV is. So how do they disclose to this child what the natural history of the disease? So you as a healthcare worker may need to to step in. And I mean, if you are the aunt and you are taking care of this child, by default, you become the parent, and you should be taking it up. So it's all the above. But people did very well, 82%. Thank you so much. I want to take you back to the case now.
Yes.
Because I feel like it's slightly more challenging than what we are seeing. I'll tell you in my own experience, I don't know if I can even do it for the children of my own relatives. It's just so complex. And I think what somebody mentioned about, there's also that sexual connected. You will have to talk about sex if you talk about HIV. I know, Rodrigo, you had a comment. Please go ahead with your comment before we go back to the case. Do you mind unmuting them, Chatonda? I know, Patrick, you're on the phone, but we want you guys to comment. You had a comment that was quite good. Patrick, Rodrigue. Yeah, you had said. Rodrigue, please go ahead. They have a network issue.
Yes, Doc. Hello, Patrick here.
Yeah.
Thank you, Dr. Rokaya, for a wonderful presentation. And my observation has been that with the much effort which we have made in trying to address the issue of EMTCT, eradicating the issue of mother-to-child transmission of HIV, now we are having this generation of adolescents. Of course, we are having the adolescents that are already infected and those that are not infected. So if we're not going to put all our efforts together toward addressing the issues of adolescents, we're going to, the idea of HIV epidemic control will be a far-fetched milestone, because those that are already infected, they are having, of course, sexual relationship with their fellow adolescents, the youths, and even adults. So if they are not adhering to treatment, then we'll have a problem, because they won't get suppressed and they'll transmit the virus. Also, for those that are not yet infected, if we won't really scale up the HIV-related informations, they will get infected. So based on your presentation, we have heard that the population of adolescents who are HIV positive is likely to double, maybe to increase by 2030. So we really have a lot of work to do to ensure that this disclosure, we need to really mentor, train our counselors, healthcare providers, and in some settings, we always encourage the issue of adolescent support group, caregiver support group for the caregivers of the infected pediatrics and adolescents, because you realize that as a healthcare provider, sometimes we do have barriers in trying to mentor them on how they can disclose. But I remember, Dr. Rokaya, if you can recall well, there's a pediatric conference we had, which you hosted in 2017, and from Mukushi district had presented that case that they are mentoring the caregivers for the adolescent to be able to mentor other caregivers who are having challenges in this disclosure, because you realize that some caregivers have done it well in disclosing to their adolescent who are HIV positive, but a lot of them, what is there that is phobia. Like if I tell this adolescent or this child that he or she is HIV positive, how will it be? So we can really, like the way we are doing it with the DSD models, so we need to bring them together, and then those that have done it also, they can teach others. If we want mentor them and ensure that our adolescents, they are aware of their status and able to adhere to treatment, epidemic control will still be a challenge for us, because if they won't get suppressed, they will still transmit, and they will have a new population, a new group of adolescents who is still getting infected, and the chain will go on. So thank you so much for the presentation, and we just need to work together, synchronize all our efforts, and ensure that we address this issue. It's a challenge that most of our caregiver, our providers, they are unable to disclose. Even the counselors in HIV clinics, they're so much comfortable with the adults than the adolescents. It's quite a challenge, and we need really to spearhead that.
Thank you so much, Patrick. If you go to your chat boxes, I've just opened up mine. You will see that Makando, who's one of our IT guys, has uploaded the toolkit for disclosure, so we can have a look. I think one of the most important things I've learned today as a healthcare worker, I know when I did my pediatrics training for infectious diseases, if someone has not disclosed, I would get really, really I wouldn't know what my role is, isn't it? But if the parent says there, you really don't want to go into it. But at a certain age, you know that you need to involve everyone. And as a healthcare worker, I know we write in the file, child not disclosed to. Actually, if you write that, just know it's your responsibility, and it's a bad indicator for you to keep writing child not disclosed to, because it's our responsibility to engage the family and to initiate the disclosure processes. So I know Mr. Chanda Muliman Senga, I was trying to find your camera to unmute you, but I can't. So he says that adolescents are the bridge that join childhood to youthhood. I've never heard that before, but said childhood to youthhood. We have no choice but to zero in at this bridge if the generation has to cross over into a youthhood and adulthood, being free from HIV. So he says that we have to zero in, and I think this population will become, because children, once we eliminate HIV, they'll become adolescents. They go to university. They also start reinfecting. But I think one of the key things when you are disclosing, like for your child, do you want to zero in on this child before I go there? So who should disclose to this child who's staying with the brother, but he's never home? The sister-in-law is taking care of this child. This child is suppressed now. He's 12 years old. He's grade 6. So it tells you something about his development, that he's okay.
So for me, I think we need to arrange to have a meeting with the child, the sister-in-law, and the father. We need to engage the brother, sorry. So the brother needs to be called in, and we have a meeting, the three of them, and then we start from there. Once for the brother to reassure the wife that she can be in a position to support the disclosure. And of course, we would want to explore what's going on in the home as well. What kind of, how is the child being treated? He seems ready emotionally and cognitively and developmentally, but it's just the issues that we need to discuss is with the caregivers before we allow them to begin the disclosure process. If they need help, then as healthcare workers, we can intervene and help them with the process of disclosing.
Mercy, is that okay, that recommendation, that you need to bring in the brother to sit with the sister and start that discussion and ask the brother if it's okay for the sister not to do it or if he can do it? How is that recommendation?
That is okay. Actually, we have even started the process. We have called the brother who has agreed to find time, sometime I think in August. That's when he says he'll be free. Yeah, so we have made a date that we meet, himself, the wife, and the child.
Yes, so as much as we are saying a non-parental caregiver can give, we need to think about who that this is not an aunt or a what. This is a sister-in-law. This could be a whole marriage at risk. Sometimes science and the social issues, they don't mix, eh? So you need to be able to get a balance. So what information should be given at this point? I'll ask Dr. Chimika to just zero in on this, what he thinks, because he's a pediatrician who also works in HIV, to just summarize this for us, what he thinks of everything and about this child. But what info should we give this child who's 12 years old? He's in grade 6. I don't know if Chilenge wants to comment. I know that they put up something. Chilenge, Onoya, and Tim, just unmute yourselves. What information should go into the counseling for this child? Remember, they will meet with the parents. What should the child be told? What are the key issues? Chimunya, I know you are there.
Yes, Dr. Sombo. So we know that at 6 years old, the child start going to school. So we also think that maybe there is a need to strengthen the HIV training program in schools, because if they can get some information from schools, it will make things easy, maybe at the health facility or at home.
Okay, so this. Yes, Chimunya. I want about this child. What information go into the disclosure for this child?
I think in addition of just disclosing and telling her about her HIV status, it's important to also talk about prevention measures, because this is already a 12-year-old, and by 12, most of our children now are already sexually active. So it would be important also to talk about prevention I think that's what I can say for now.
Like what sort of prevention, Chimunya? Is that viral load less than 20?
The viral load is less than 20. Still,
yes.
we need to talk about
we are just from this campaign, You Equal You. I think it has been launched. So it's important for this child, though the viral load is suppressed, but to sustain it is also important.
Yeah, I think I agree, right? I think the important thing when you are giving people information that's very serious like this, like if you are dealing with a diabetic patient, for example, and they're at a good place like less than 20. So you tell him there's a future for him. If he stays less than 20, he can get married and have children and have a normal life like anyone else. That's very important in the disclosure, isn't it? As opposed to defining AIDS, there will be PCP, Kaposi sarcoma, you have crypto, but you also say, you know, at less than 20 and this CD4, really, you can even grow up, go to university, become whatever you want to be, get married, have children, look at your viral load. All the positive messages need to go in there. I don't know, Messi, if you have something to say before we allow Dr. Chimika to just wrap up in a minute or two. Is that recommendation okay? What information should go into?
I think that recommendation is okay. When talking to this child, it's like he knows about HIV.
Okay.
He's learned something in school. So it's like we have somewhere to start from because he knows the basics. So yeah, positive messages are quite important.
Yes, as suppression, it means you're reducing the inflammation, it means you are less prone to OI. They need to hear all that, isn't it? And also, we shouldn't be 10 of us when we are disclosing because the child will be very scared.
I just want to make a comment about the school. I think a lot of times, I hope it's changing, but the messaging at school for a long time has been very punitive, like don't have sex, you get HIV. Therefore, you die if you get infected. They don't consider that there are children who are perinatally infected and already on treatment. So the support for those who are already infected is kind of lacking, and the schools need to be more aware of how to support those who have not been sexually active but have acquired HIV anyway. So that group has been kind of fallen off the support system in schools.
Yes, because when we are teaching, we're talking about HIV,
this is how it's transmitted. This is how they'll be told, don't have sex before marriage, don't do this, you get HIV. It's assuming that everybody in the class is negative.
Which is a very wrong assumption looking at our HIV prevalence, which is almost touching 13. Dr. Chimuka, just a summary of today's presentation, just your expert opinion.
Yes, thank you so much.
What's going on? Sorry, Chimika.
Maybe he can stop his video.
Can you stop the video? No, we can't. Stop your video.
I stopped my...
Oh, you're better. You're better now.
Okay, thank you so much. So I think I must commend the team. This is one of the important components in the care of the children who are living with HIV, particularly those of us out here. And I'm sure other participants have actually really appreciated. I totally agree with the team that presented, and I think just to add on, just to emphasize that there's no agreed age. Most of the time, these children will trigger. Some of them will start asking questions as early as 5 years. Why am I taking these tablets? Why am I the only one in this house taking these tablets? At school, we are told that there's HIV. So we need to be very careful, and we need to be ready to, as the presenter mentioned, we don't have to lie. We have to be very tactical. Even the kind of language that we use, we need to be careful in terms of age appropriate. Remember in the presentation they mentioned we cannot be talking about AIDS. how are you going to explain AIDS to the patient? I mean, to this child. So we need to select the appropriate form of communication such that the child can comprehend what is going on in his body. Because later on, when you want to do full disclosure, they will always relate to what you told them earlier on. And if they discover that you are lying, then definitely they'll lose trust in you. And if you are the caregiver, you may not lose it out. I also agree with the team to say the primary caregivers needs to be engaged, because if you look at the history of this child, I think the major issue here has been issue of adherence. Even when they were switching to the second line, I give the benefit of doubt whether the child truly, the failing was due to the drug failure. Probably it was still issue about adherence. If they did good adherence, probably could have seen the viral load going down in that situation. But nevertheless, is now going to an adolescent stage. You know, adolescence is different stages, early, mid, and late. Again, we see that there will be other challenges that the child or this adolescent may affecting is adherence. So we need to approach everything in totality, considering some of the dynamics that will come at play when this child attains puberty, and also all those things. You know, there's also peer pressure and the like. But what is important is, I think somebody mentioned an important aspect in terms of the peer support groups. Adolescents, usually they do very well when they hear from their fellow friends, because they can always relate. And this is very important in terms of once you disclosure, because you know they have a lot of questions. And usually there's a sense of guiltiness. Sometimes they maybe hate the parents, especially if they are late. Say, why did you do this? And then pass the virus on to me. But when they learn later on that they are not the only ones, actually there are others who got the infection through the same route, and now they are doing very well in life. They are doctors, they are nurses, they are doing very well in other professions. That actually is a positive to them and gives them a lot of hope and improves adherence. I think that is key.
Thank you so much, Chimika. I think you wrapped that up perfectly. I have no additions. I know Western Province has said also that they need caregiver support groups. We need to remember disclosure is a process. We can't say Naku in the 6 years, it's the same disease. It's a process. Today you say one thing, tomorrow. And as Dr. Chimika said, they'll trigger the process. If they are 5 and they're asking, answer them. Don't say, 10 years. Isn't it? But Dr. Chimika, thank you so much. You did that perfectly. Next Monday is a holiday, right? Madam Nomsa? It's a holiday, so we will not have echo. We get some rest, but the next Monday we'll be talking about the HIV screening tool, which is really a big deal right now. We are trying to avoid over-testing because the country currently has low stocks of HIV. So I want to give the people that need an HIV test, the ones that really need it, to have the HIV test. So it's just to prevent over-testing. We're not saying we are stopping HIV tests on people. So Dr. Albert Mwango and I think Dr. Kandio or Dr. Peter will be here next week. Thank you so much. Good discussion.
An announcement. Yeah, just an announcement. Thank you so much for those that have stayed on to the end. Been a great session. We just want to encourage you one more time. Please submit your registers. That gives us an idea of who is participating, and it's an important document in terms of tracking the people that are participating. So for the facilities, please, I urge you, you are doing well, but I think you've also relaxed now. Can you please submit your registers as soon as you drop off from the network? Thank you so much for participating. See you on the 8th of July. That's when we'll resume our echo session.
Okay.